Hello friends. So today we are going to discuss about our last problem-based learning of the week, which was a case of a 64-year-old postmenopausal lady with left-sided invasive breast cancer and early breast cancer which was hormone receptor positive, HER2 negative with a Ki67 index 40%. So after surgery, what should be her optimum sequence of adjuvant therapy? Should it be administration of radiation therapy followed by chemotherapy, or chemotherapy first followed by radiation therapy, or the sequence does not significantly impact outcome, and we requested you to provide reasons for a chosen answer. Friends, this question is important because breast conservation surgery is inherently associated with radiation therapy, and it has been emphasized that a delay of radiation therapy for more than 8 to 12 weeks after surgery adversely affects local recurrence, for which we received a very important article of sequencing of chemotherapy and radiation therapy for early breast cancer, which was from the Cochrane Library. And now we are going to discuss about this article in detail. In this article, the authors compared concurrent versus sequential chemotherapy, as well as also they compared results of radiation therapy followed by chemotherapy versus chemotherapy followed by radiation therapy, and they tried to find out the primary outcome in the form of local recurrence as well as secondary outcome in the form of overall survival, distant metastasis, toxicities, and compatibility. In sequential versus concurrent chemotherapy and radiation therapy, the authors excluded any patient with taxane or anthracycline and compared only patients who received CMF with radiation therapy. So the results were biased. However, in those results, the authors did not find any major difference between the concurrent versus sequential chemotherapy and radiation therapy, except that in the concurrent group, the physician reported assessment about the cosmetic outcome was worse. Similarly, in patients who received radiation therapy followed by chemotherapy or the chemotherapy followed by radiation therapy, the authors did not find any major difference in the outcome except that the chemotherapy dose was 88% in patients who received chemo first compared to 81% in the patients who received radiation first. To summarize, the authors did not find any major difference between the sequencing techniques in regard to mortality and local or distant recurrence. There was some differences in late toxicity, however, that was not of any clinical significance according to the authors. So when we try to find out more specific articles who try to address this same issue, which compared the chemotherapy first and the radiation therapy first group and found a significantly higher disease-free survival in chemotherapy first group if the chemotherapy is initiated within 3 months of the surgery. Similarly, there are other articles which cite that though the delay in radiation therapy for more than 8 to 12 weeks may be detrimental and can affect local recurrence, there are other studies also which cite that though a delay in radiation therapy for more than 8 to 12 weeks after surgery adversely affect local recurrence, especially when the radiation therapy is the main therapy that has to be initiated. But if the chemotherapy has to be given first, then radiation therapy can be administered within 7 months after surgery. The concurrent use of hormone therapy must be avoided with chemotherapy. However, with radiation therapy, the data is insufficient. The use of trastuzumab concomitantly with radiation therapy may enhance toxicity but may also improve its efficacy. Brandos thanks Dr. Mithun Ram, Dr. Naval, Dr. Umang Mittal, Dr. Shabnam Bashir, and Dr. Chintan Safi for their active participation and contributing academically to this discussion. We look forward for more such discussion. Stay connected.